So the first part of the exam we're going to look at is bradykinesia. When you have patients do the rapid alternating movement, it's important to have them go both as big as they can with the movement and as fast as they can with the movement. If you don't give them those instructions, they might go really big but slow or really small but fast. You have to have them do both or you'll miss some subtle changes. And the three movements you can do is finger tap, hand open close, and pronation supination. Tap your thumb and index finger as big as you can and as fast as you can. Good. Let's try the other hand. As big as you can and as fast as you can. Okay, so now we're going to try a different maneuver. So sometimes when the patients have arthritis, they can't do the finger taps properly, so there are a couple of different ways that you can do this. One of them is fist open close. So Larry, go ahead and make a fist for me, open all the way, keep going. Big as you can and as fast as you can. Good. And with the left hand, the same thing. Big as you can and as fast as you can. Very good. Another movement you can do is pronation supination. With the right hand, put the hand out flat like that. Palm up, palm down, palm up, palm down, as fast as you can. Good. The left hand, the same thing. Up, down, up, down. Finger tap tends to be the most sensitive movement. The smaller movements in Parkinson's tend to pick up the bradykinesia the most. So you can also look for bradykinesia in the lower extremities. The most sensitive maneuver to do is toe tapping. So what I want you to do, Larry, is put your feet a little bit closer to here. Perfect. Keep your heel on the ground. And with your right foot, I want you to tap your toes big and fast. Good. And now let's try the left one. This one's a little harder. You also want to look at the change in the movements. So do the movements get slower over time and do they get smaller over time? Which means you have to do enough of the movements to catch that. Usually 10 repetitions is enough. So as you see through the entire movement, there's a slight reduction in the amplitude and a slight reduction in the speed. That's what you're looking for. All right, so the next element we're going to look at is rigidity. So the key thing here is getting the right amount of relaxation, which we all know can be very difficult. So Larry, I want you just to relax your arm as much as possible, and I'm literally holding the weight of his arm in my hand. I can feel the weight of the arm, so I know he's really relaxed. The most sensitive place to look for rigidity is actually in the wrist. And so I'm going to do a circle wrist maneuver while I'm holding the arm. And again, this is completely loose. I don't notice anything. And I can see that I can get a full range of movement and there's absolutely no resistance to that whatsoever. I can get nice full movement here with no resistance. So I need to do an activation maneuver. Larry, with your left hand, I want you to tap on your knee like right there, nice big taps for me. Big, big, big taps. And there, that's when I catch the rigidity. And here, it's just a little harder for me to get that full range of movement, but I'm able to get it. I can also catch it in the elbow here a little bit, but I have to do the activation maneuver because his medications are working so well. With the lower extremities, it can be a little bit more difficult. So a way to get the patient to relax is to literally put the weight of their leg onto your arm, and here I can tell that he's completely relaxed. Again, I'm going to look at the ankle movement, and I'm going to look at the knee movement. But this is completely loose, so I'm going to have him do an activation maneuver. Larry, with that left hand, can you do nice big taps on your knee for me? There, and I catch just a little bit of resistance to the movement with the taps. Go ahead and relax. Sometimes you'll feel a tremor within the rigidity. People refer to that as cogwheel rigidity, and all that is the tremor superimposed in the rigidity. So if someone doesn't have tremor, you don't get the cogwheeling. Oftentimes, you'll notice some changes in bradykinesia, rigidity, tremor on exam, but it's not really bothering the patient. And if it's not bothering the patient, you won't necessarily change your medications or do any intervention. But if you see changes in the balance and gait part of the exam, more difficulty with their walking or some balance problems, that obviously puts them at higher risk for falls, and you want to be more in a preventative mode. So we're going to look at standing up from the chair, we're going to look at just free walking, and then we're going to look at balance with a provoked pull test maneuver. So I have them put their arms over their chest and then try to stand up in just one movement. Very good. Excellent. Go ahead and have a seat. Notice I kept my arm behind the patient just in case he had some difficulty standing up and he fell back into the chair. He wouldn't hit his head against the wall. If the chair's next to the wall, that can sometimes happen. The next part is just walking. And really, this is just watching the patient walk back and forth up and down a hall. It's best to have at least 10 feet of hallway to really get a good enough walk. But you want them to walk back and forth several times, observing the turns, observing the step length, seeing if there are asymmetries between the step, looking at the heel strike. Are they picking their toes up or are they shuffling and scuffing their foot? And you want to look at the arm swing. What you might see is an asymmetric step where they're kind of a flat foot on one side and a heel strike on the other, or they might just be taking small shuffled steps like that. What you might see is an asymmetric arm swing where the person is swinging one arm but not the other. So let's go ahead and do some observation here with our patient Larry. And here's an example of symmetric step and reduced arm swing. And here's an example of some shuffles from Parkinson's. So the last part of the gait and balance exam is the pull test. What I actually want to know is that if I pull someone off their center of gravity, can they correct their balance in 1 or 2 steps? They're at risk for falling if they can't do that. When I do this test, there are a couple of key things. First of all, I always make sure there's a wall behind me. If something happens and the patient gets off balance, I grab them and we both fall into the wall and no one falls onto the ground. And it's a really safe way of doing this so that nobody gets hurt. The other thing I do is coach the patient and make sure they understand what I want them to do. So Larry, I'm going to give you a tug backwards on your shoulders, and what I want you to do is take 1 or 2 steps back to catch your balance. The first one's going to be practice. On the count of 3, step backwards. 1, 2, 3, step. Perfect. That's exactly what I want you to do. This one's real. I'm going to give you a tug. I'm going to want you to take 1 to 2 steps to catch yourself, and I'm right behind you. I won't let you fall. Ready? Good. Now I'm going to pull you a little harder. Good. One more time. Excellent. So as you can see, Larry was able to catch his balance in 1 or 2 quick steps. If someone takes more than that and their center of gravity gets too far, they might take 3 or 4 or 5 steps, but still be able to catch their balance. But that makes you a little worried that they might be at risk for falling. Other patients might take a couple short steps, but their center of gravity gets so pulled off that they can't catch themselves, and you need to stabilize them in order to keep them from falling. Those are the things that you're looking for on the exam.